things will change as time goes on. So that picture was taken when I had more hair and less fat, but so things will keep changing. And I have taken the liberty of saying that to do this as what I think will be the practice of critical care maybe in the next 10 years. We can't predict what's going to happen 100 years from now. George Orwell did it pretty well when he said Big Brother's watching, and now Big Brother's watching our every move via Google or whatever it is. So, and this is a personalized view, so it's not evidence-based, and I'm sure someone else can say, but no, you should have said this also and that also. But this is my personalized view, and try to a little bit what I can say in about 25 minutes or so. So I think the drivers for change, critical care will change, of course, and the drivers for change, I think, will be based on changes in epidemiology, and very importantly, as we are seeing even today, the social and economic factors, the social and economic environment that we are going to practice in, and of course science and technology is going to change things. So one of the things that we need to do is, we need to know what our problems are, and the INDICAP study was one study which did it, and a big problem in all ICUs is sepsis and septic shock. And what the INDICAP study showed us was that mortality in patients with severe sepsis and septic shock in Indian ICUs was 34%. Now that's a huge mortality, and that's a problem not only with India but all over the world. And so I think let's try and see what I think might happen with sepsis management over the next few years or so. I think one of the biggest problems when a patient presents to us with severe sepsis and septic shock is we give antibiotics, and we give empirical antibiotics, and you have lectures and lectures and lectures on how to give an empirical antibiotic, and whether it should be this or that one, or colistin or meropenem or whatever it is, all these megapenems and gorillamycins and all that we give, and it's all empirical for the simple reason that we don't know what the underlying infecting organism is. So today we've got technology which is coming up, right? We've got technology which is coming up which is going to allow us to make a rapid microbiological diagnosis. Unfortunately, we've got two types of systems. One is based on first getting a culture positive, and then you'll get identification sensitivity like the Malditoff and so on. And on the other hand, you've got very, very sensitive tests which can be done on blood without having a culture, and you're going to use basically some PCR based technique, and that can give you the bug very, very fast. And I think if we have the adequate technology, and this will be a PCR or spectrometry or spectrophotometry based technique, we will be able to get our identify our organism, okay, within a couple of hours, maybe even less than that, and not just identify organism but even the sensitivity, and whether it's a resistant bug, whether it's not a resistant bug. And if we can get that information in 1, 2, 3, 4 hours, then I think empirical antibiotic therapy will be a thing of the past, and we will be able to treat our patients more precisely with less side effects and without the problems of more or newer antibiotic resistance. We are already stuck with the problem of antibiotic resistance, but maybe if we get a precise diagnosis very early, we may be able to save antibiotics, not blast everyone with all sorts of drugs, and give very specific treatment and hopefully better outcomes. We know a lot about how to give antibiotics. We've been introduced to this concept of PK/PD, pharmacokinetic and pharmacodynamic profiling, and we know that if you give aminoglycosides, they are concentration dependent antibiotics with a post-antibiotic effect. So you give a big whack, a big dose in the morning, and that will take care of it. On the other hand, you've got beta-lactams like meropenem, the piperacillin tazobactams, which are time dependent. So what is most important is the amount of time, or the proportion of time that the antibiotic level remains above the MIC of the organism, and there are those which depend on both concentration and time. Okay. The problem is, the real problem that we face today is, how many of you would give a Noradil infusion without measuring blood pressure? How many of you would set the FiO2 or the PEEP without looking at the oxygen saturation? So no one would do these interventions, which are very critical interventions in ICU patients. But the most important intervention in a septic patient is antibiotics. And the only thing we don't know is have we reached the adequate drug level. We know that drug levels are altered for so many reasons in sepsis, right? You've got a high cardiac output, you've got increased vascular permeability, you've got drugs leaking out, you've got augmented renal clearance, you can get high levels because of renal hypoperfusion, you can get high levels because of liver dysfunction, but we don't have a clue as to what the antibiotic level is. We don't know what's the antibiotic level in the blood, we don't know what's the antibiotic level in the lung, we don't know what's the antibiotic level in the bile. And here we are treating bacteremias, pneumonias, biliary sepsis and all sorts without knowing anything at all. We know how to work, we know the principles, but we can't measure. And I think the next big step after big diagnosis of antibiotics, of the bug, is to be able to measure the drug concentration of antibiotics. But simple tests. Today, if you want to do an antibiotic level, you have to get a HPLC column, you have to take it to a lab with technicians and so on, and then they'll give you a result. But if we have bedside tests, something like what you do, a drop Ts and so on, the troponins, the point of care tests for antibiotic levels, and they will come up and they have to come up. And I think one of the big things that we must, as a community of intensivists, drive research or force the industry to do is to actually develop point of care tests for antibiotic levels, and that's when we'll be able to get our things much better. So I think in the near future, we will have better methods of diagnosing sepsis. We'll be able to, with biomarkers, for example, procalcitonin, which is not great, but still something which is there. You can diagnose infectious from non-infectious conditions. Empirical antibiotics will be a thing of the past, right? I hope that will happen with rapid molecular testing. We will be able to optimize our dosage with therapeutic drug monitoring with point of care tests, or at least rapid drug assays, okay? And we will also be able to de-escalate, again based on biomarkers or some other markers, so that we can get a diagnosis, give as little antibiotic for as short a time as possible. So I think sepsis management is going to change. All the technologies in place. We just need to make it available, more affordable, and need to validate some of this technology, and then I think we'll go there, and that should happen in the next few years. What we also need to do is a sort of public health kind of thing for sepsis, especially in our country. In the US, you have, we all quote CDC figures. There are so many million cases of sepsis, and these are the sorts of organisms. We don't have national data for our country. We don't have, so we must have that. We must have dissemination of the guidelines. The problem with almost all the intensive care that we have today is we have immense knowledge. We have tremendous knowledge. Everyone reads journals. Tomorrow I'll tell you about the thing which came on PubMed 5 minutes ago while I started speaking. Okay, so we have the knowledge. The problem is implementation. How do we implement guidelines? How do we make sure that everyone in the ICU follows the standard bundles of care? How do we ensure these things? And that will make life safer and better for our patients. So we need implementation medicine is something which we really have to follow. And what are the barriers? Why people do things? Why people not do things which we know are beneficial? That sort of thing. So we need a national process of surveillance, antibiotic resistance. It's happening. We've got the ICMR network. We've got this thing. It's all happening. But it'll all probably come together in the next few years. Monitoring is the heart of intensive care. I mean, if anyone comes to the ICU, the first thing they see is all these glitzy monitors beeping here and there, and all these lines flashing and bright colors and all those things. And I'm not going to tell you what's going to be monitored in the future. I mean, you can just go on finding things to monitor. But what is going to happen to monitoring, it's going to be largely non-invasive. And almost many of the things that we are doing invasively today will become non-invasive. Many of the blood tests that you do will become percutaneous continuous sampling. For example, glucose levels, right? So it'll become something like that. You'll have a CT scan almost the size of your ultrasound machine. So you'll have miniaturized CT scans or MRIs almost at your bedside. And we'll talk about expert systems and intelligent monitoring systems. So today you've got a patient who's on a monitor. He's hooked up to different monitors. He's hooked up to syringe pumps. He's hooked up to a ventilator. He's hooked up to a dialysis machine and everything. Now today it is possible to connect all of these via a common server, and you'll get the output from different machines, different pumps, different monitors on a common monitor, and even on your mobile phone. So it's all possible today. So remote monitoring is definitely possible. But what is going to be more important? What is going to be more important is that the monitor is not going to be merely a monitor. Okay, it's not going to be merely a monitor. Firstly, because of algorithms which doctors will help devise, the engineers will create software. They'll create software so that when the patient meets certain sort of criteria, certain numbers over there, it will actually prompt an alert. It will give an alert, and that alert can be heard by anyone, whether he's in the ICU or he's outside the ICU. For example, if the patient has a saturation below 90%, a peak airway pressure on your ventilator more than 35 millimeters of mercury, a blood pressure drop more than 20% from baseline, that combination of parameters will set off an alarm. And someone who's there at the other end will say, oh my God, he's got a drop in saturation, he's just been put on a ventilator, he's just had a subclavian line put in, he's had a drop in saturation, he's had a drop in blood pressure, and he's got a high airway pressure. Possibly we are looking at a pneumothorax. Okay? So something like that will happen, and those prompts will come up over there. What is even more exciting is a field called bioinformatics. Okay? All of us have a genetic signature, and today our entire genome can be sequenced and it can be stored. So we'll know this is Gopal, this is Shyam Sundar, this is everyone. So we'll all know that. If someone falls sick, okay, we'll have all his data, including his genetic data. Okay, will he survive? Will he respond to therapy? Will he not respond to therapy? So this will be stored on your hospital computer. This hospital computer will talk to similar and the computer will do the rest. It's going to happen for many, many things. It's happening already for ambulatory glucose, for insulin levels. So it's going to happen in intensive care as well. What is the implication for it? Will it destroy the patient-doctor relationship, or will it enhance the patient-doctor relationship? It might give me actually more time. It will free myself from calculating all these sort of things and give more time maybe to talk to the patient, more time to talk to the family and tell them what's going on. But this is going to be something which is going to happen in the future. So closed loop monitoring or closed loop systems are going to come into place. We mentioned about precision medicine, and Dr. Sriram Sampath in the morning said we don't have a diagnosis. Sepsis, ARDS, but why sepsis? Why ARDS? Why do some patients with pneumonia sail through with oral antibiotics, and why do some patients with pneumonia die of septic shock? Right? Is there something in their genes? Is there something in the way the genes are expressed in the presence of some bacteria? We don't know. But with precision medicine, with genetics, with molecular markers, we will be able to identify this. Within that pool of pneumonia, we will identify beforehand the bad ones. We will be able to identify the ones who get septic, who are likely to die. Within that group, we are going to identify the ones who are likely to respond to a particular class of antibiotics better than others. And that is going to help us, is going to risk stratify patients into low risk and high risk. And when we'll be able to specifically treat patients with one particular group of drugs or one particular type of techniques as compared to others. And this is going to be the future of precision medicine. In cancer, precision medicine is a key. Lung cancer is not lung cancer anymore. You either this mutation positive or that mutation negative. If you're this mutation positive, you take Jeftinib. If it's that mutation negative, you take something else. Leukemias are exactly the same. So cancer is going this way, and intensive care is not going to be far behind. Okay. The problem is, there have been lots of studies on genetics in sepsis, how the genome is expressed in sepsis, which genes are expressed, which genes are suppressed, which genes change. The problem is, someone who just begins sepsis, someone who's been treated with sepsis for 1 day, someone who's been with sepsis for 5 days and is likely who's not doing very well, the gene expressions are very, very different. And to get enough data from different types of patients in different stages of sepsis, with different etiologies of sepsis, is very hard to reconcile all these things as of today. But with bioinformatics, with more and more people doing these tests, with more and more of this technology coming up, this is also going to happen. So we will have precision medicine in sepsis, okay? In sepsis, in ARDS, we already know there are some genes which cause ARDS or which make ARDS worse. Now, all this is going to be the glitzy, glamorous and the sexy part of intensive care. But, high-tech, genetics, genomics, epigenetics, all those sorts of things. But I think we also need to focus on some of the not so good parts of intensive care. We will, like I said in the morning, we are saving lives. More and more patients are surviving, but the quality of survival is a problem. The problem in all these survivors of ARDS, psychiatric disorders, illness, anxiety, depression, post-traumatic stress disorders, another study, again long-term depression. So we are going to see more and more patients, as we save more and more lives, we are going to see more and more post-ICU problems. And while we are doing intensive care, we must be able to minimize or prevent these problems. Carbon dioxide. Once you remove the carbon dioxide, half the problem is over. Treat the patient, get rid of his bronchospasm, get rid of his infection, and that's happening in many, many centers of the world. So I think in the years to come, intubation is going to be even less. They're looking at ECMO in ARDS prior to intubation. Don't intubate, put in ECMO, put in catheters. Instead of here, you go in from here. Okay? And it meets all the criteria for resting your lungs, protecting the lungs. The problem that people are having is that patients with ARDS are very, very breathless. Even after you correct the hypoxia, the drive is so high that they need some sort of support to prevent dyspnea. And maybe with morphine, and maybe that they'll control the dyspnea and they'll control the oxygenation of the ECMO, protect the lungs. That seems to be happening. Okay, we have to be involved outside the ICU. In the morning, we spoke of medical emergency teams and post-ICU follow-up clinics. We must also be more socially relevant, right? In other words, we have to participate in disasters. We stay away. We're moving outside the walls of the ICU. We have to move towards disasters. Infections, especially epidemics, they may not be epidemics, but we are going to have spate of these respiratory viruses and new viruses which come up, and intensive care. The intensivists are going to be squarely in the center of it. We have to be involved in that, and we have to learn how to make ourselves safe, right? I am so worried that if a SARS-like epidemic comes to India, we were spared. I'm sure intensive care can become affordable only if our public hospitals are upgraded, public hospitals are modernized, better staffed, better equipped, and it must be done, and only the government can do that. They can take help of NGOs and charity and all, but ultimately I think the government has to assume some responsibility beyond mere price capping and stuff like that. Of course, education and manpower development has to take place, and we have to do all our work, and end of life is also one of the big things. So in summary, we need to improve the quality, performance, efficiency and accountability of our public and private health systems, and we need to strive for solutions to make our ICUs safer, and all this will happen, okay, along with technology and everything that is there. So thank you very much for listening.
Wonderful talk, wonderful lecture. Because of the nature of the topic, I don't think